Hello. Okay. All right, I think Is that on? Okay. All right, we're going to get started. If you guys want to go ahead and get seated. Okay. I'm going to go ahead and just do a little housekeeping really quick before we get started. If you did not sign in, whether you're claiming CME or not, if you could please sign in, because it will make sure that we have your most current information for when we're reaching out about other programs or sending you any information about the session. Stay on it for a second. Okay. This next QR code is for the pretest. If you are claiming continuing medical education credits, then we do prefer that you complete the pretest. And at the end of the session, anybody that signs in, I will send you the information on how to claim your credit, which will be the post-test, the evaluation, and then the claim credit form. Here are our faculty today. Everything that I'm presenting to you right here is also in your guidebook and the little clear bag that we gave you when you checked in. But I thought that I would display them here because we're very excited about our lineup today. Here's our agenda. This is also available in your guidebook. I do want to point out two things. At the break, we have an ancillary event that does not offer CME that will be over in the boardroom. So at 3:35, if you guys want to refresh, go to the bathroom really quick. And then if you want to attend that, I'll be walking around flagging you down too, but it's behind us in the boardroom. Also, we have the networking event from once the conference concludes today around 6 o'clock, where we're going to have some beer and wine, and it's an opportunity for you to interact with faculty as well as our gold and platinum sponsors. This is a handout that's also in your registration bag. This is the information about that non-CME ancillary event that's being held over in the boardroom at break. And last but not least, of course, thank you to all of our sponsors and exhibitors. You are the reason that we're able to pull together these programs in the winter and the summer. Without you, we wouldn't be doing this. So thank you very much. And I'm going to go ahead and Dr. Kinney is going to come up. He is our session chair. And he's going to be introducing the speakers as well as moderating the session today. Thank you. Yep.
Okay, my name is Amit Kinney, and I'm really excited to chair the session. We've got a fantastic lineup of speakers, so I'll keep this short. We have Dr. Sanchez and Dr. Avila, who will be talking about myeloma. And we have the esteemed Dr. Rubenstein, who will be talking about lymphoma. And finally, for our keynote address, we'll have Dr. Chadi Naban, who'll be talking about something that a lot of us have been thinking about but don't quite understand, and that is artificial intelligence, AI. So he'll be talking about AI in oncology. And, you know, as I was preparing for this session, I got a flashback to like more than 25 years ago when I was in training, and so was Dr. Naban. This was in Northwestern in the late 90s. And I had a poster at the ASH meeting, and it was about angiogenesis in myeloma. And at that time, that was like a hot topic of research. And some smart people had this idea of trying out thalidomide, which was a notorious drug, right? Which was like banned. And they decided to use thalidomide for myeloma. There's the Barlogi group and a few others. And lo and behold, it worked. And so that, you know, led to the thalidomide analogs and the proteasome inhibitors, the anti-CD38 therapies. But to me, it seems like the pace of change in all these myeloma, lymphoma has been accelerating in the last few years. And so we have our speakers who will talk about it. And our first speaker is Dr. Matias Sanchez. Dr. Sanchez is a highly trained hematologist oncologist at the University of Illinois Health, trained in multiple places, including Memorial Sloan Kettering, and he's an expert at UI Health in multiple areas, including plasma cell myeloma. And today, Dr. Sanchez will be talking to us about the next phase from innovation to integration, the next phase of T cell engager therapy in myeloma. Dr. Sanchez.
Hi, everybody. Thank you all for your support to this event. We're very happy to be here. So what I'm going to be talking today is about CAR T cells and more what we're mostly learned from ASH last year, which is has been really interesting. Those are our disclosures. So the talk would be focused on the follow-up on randomized studies on CAR Ts, also on real-world efficacy data, some predictors of response and mostly toxicity, and finally about what new products we have coming in the future for this CAR T cell. So on the, regarding the first topic, this was a study that was presented by Dr. Luciano Costa about the long-term results of cilta-cel in the first relapse after lenalidomide refractory patients in second and lines and beyond. As you all know, patients with CARTITUDE-4, which is the study that is the first study to demonstrate an overall survival benefit in patients who used cilta-cel as second-line agent compared to standard of care. This was the most recent update from that we learned about last year at ASCO. So what the study that Dr. Costa presented is focused mostly in standard risk patients. Those patients, how good are they doing after this therapy? That was the goal of the study. So this was the design of the CARTITUDE-4 study, which in patients with 1 to 3 lines of therapy, and refractory to IMiDs, basically, and they were randomized to receive cilta-cel or standard of care arm, traditionally Dara-Pom-Dex or Velcade Pom-Dex. Basically, the primary input for the study was progression-free survival. And the study is focusing on, again, on standard risk patients, not high-risk patients that we, and they also included patients with 1q gain abnormalities. So as we all learned from the CARTITUDE-4 study, the PFS and overall survival benefit all risk cytogenetics patients. However, if we look at basically high-risk patients, patients who do not, I mean, standard risk patients who do not have deletion 17p, 414 or 1416 translocation, look at that PFS, it's close to 80%, and similar to the OS. If you add 1q gain, which is traditionally described as a high-risk abnormality, it's still not as good, but still very good results. So what this study highlights for the most part is we're approaching in standard risk patients with myeloma in second line and beyond what we can call a functional cure. This is mostly like a survival curve of Hodgkin's lymphoma patients now. So this is a very important study, and we will see cilta-cel incorporated as a second-line agent and beyond. So here's when we compare the results with the cilta-cel in CARTITUDE-1 study in patients who had more than 4 lines of therapy, median of 6 prior lines of therapy. We can clearly see that PFS of 30 month was close to 60%. Now with as a second-line agent, the results, the 30-month PFS is closer to 80%. So it is encouraging. This is moving cilta-cel as into earlier lines of therapy, which is we're very happy to see these results. So, however, cilta-cel comes with side effects and toxicities. One of them is, most importantly, delayed neurotoxicity. For the most part, as we remember, delayed neurotoxicity that presents after a month of or beyond infusion. Most importantly, Parkinsonism, cranial nerve palsies, and peripheral neuropathy. And it presents in about 10% of the patients. And what this study is trying from Mass General tries to demonstrate is correlate, are there any markers that help us define which patients will present with delayed neurotoxicities? Some studies that we've seen were presented last year clearly demonstrated that an absolute lymphocyte count, the peak absolute lymphocyte count was really correlated with increased risk of neurotoxicity. Other studies presented at Tandem last year, there was demonstrated that there was an association with reducing neurotoxicities when you used dexamethasone as prophylactic therapy in patients with an increased absolute lymphocyte count. So in the study, they used 2 cohorts of patients from 3 institutions who had lymphocyte counts at different time points, and also expansion of the flow cytometry CAR-T expansion measured by flow cytometry. Most importantly, if they measure the CAR-T cell numbers between days 7, 14, and 28, 21 and 28 days. And interestingly, the peak absolute lymphocyte count was related with increased risk of cytokine release syndrome that we know, acute neurotoxicity ICANS, and also related to delayed neurotoxicities, cranial nerve palsies. Mostly all the side effects that we've seen. The correlation, there was a correlation between the CAR-T cell proliferation with the absolute lymphocyte count. So there was a concordance between ALC and the peak numbers of the CAR-T cell levels. And here we can see that the highest expansion was in patients with Parkinsonism was with a peak CAR-T cell levels between days 10 and 15. The other patients with other neuropathies did not develop this high amount of lymphocyte counts. So they established the best method to the threshold to use any intervention. They described the lymphocyte count over 3,000 was the best marker of delayed neurotoxicities, including Parkinsonism as well, or even a 2-fold increase in the lymphocyte count from if they have a 2,500 in the lymphocyte counts. So another study was trying to, from Mass General, try to profile what type of the lymphocytes counts are in CAR-Ts are present here with different CAR-T cell products using cilta-cel, ide-cel, and anito-cel, and they performed, Dr. Keeney knows here, flow cytometry, but also next generation sequencing in 3 groups of patients that received these CAR-T cell products. And they demonstrated that patients had a high ratio of CD4 CAR T cells with a specific transcriptome profile, which HOP-X is a marker of T cell proliferation and activation, which can explain specifically with patients on cilta-cel, not on ide-cel or anito-cel, had this signature though. So this is the main, what can potentially translate into a causation of whether this CD4 HOP-X T cells are causing CNS toxicity. Similarly, this retrospective study presented at Mayo using dexamethasone in patients with high levels of lymphocyte count greater than 3,000 compared to an arm that did not receive steroids, unfortunately did not find any difference in delayed neurotoxicities when using dexamethasone prophylactic 10 milligrams BID for 3 days. So we know, in summary, we know that peak ALC correlates with neurotoxicity with cilta-cel. Dexamethasone, unfortunately, is not an effective therapy for this. So further studies are needed to find which is the safest product and what we can do to prevent the delayed neurotoxicity, which there is no treatment, effective treatment for that. That's the main issue. Now, changing gears about learning cilta-cel in the real world. This is a CIBMTR analysis. Traditionally, we've been using cilta-cel specifically in very fit patients, patients who have good performance status and no real comorbidities. In patients who are frail or with comorbidities, we use either ide-cel or bispecifics. But this study is looking into how patients in the real world, frail adults, behave when they receive cilta-cel. This is a retrospective studies of all the institutions who report to CIBMTR, and there were 183 frail patients. They were defined as frail by the myeloma working group criteria, which includes ECOG performance status and a comorbidity index. And 30% of these patients had were classified as frail. So when we compare frail and non-frail patients, definitely frail patients have inferior progression-free survival and overall survival with, however, the numbers in comparison look pretty decent with PFS of 75% in the 62 and 75 of the frail and non-frail patients respectively. Similar overall survival, 78% at 1 year and 90% in the non-frail cohort. The most common cause of death for everybody was a relapse of disease. That's always no side effects, but the myeloma, refractory myeloma. There was a higher rate of CRS and ICANS in patients who are frail. That's something we already knew about. And similarly to non-ICANS infections were also common in non-ICANS neurotoxicity. There was a small numbers, but still higher, no statistically significant difference between frail and non-frail in delayed neurotoxicities. And this is, I think, the most important slide in terms of treatment-related mortality. The numbers were, it was a 6.8% mortality with cilta-cel. So I think this data can help us gives us more guidance in terms of can we give this therapy to an older, frailer patients since cilta-cel clearly has the best, on all of the cell therapies that we have in the market is the one with the best response. So I think with this data, we can certainly use cilta-cel in frailer population, obviously measuring ALCs and all the comorbidities that patients can have. One last thing, infections were high also. So we also remember to give our patients IVIG or antimicrobial prophylaxis and all those prevention strategies that we use. How about, interestingly now, novel CAR T-cell products that we saw that this is where there was a interesting ASH related to this. One of very interesting product that kept everybody talking about is this study from China using a CAR T cell product in BCMA and CD19, dual targeting CAR T cell product. So as you know, BCMA, all the CAR T products, most of them target BCMA. However, cells, B cell precursors also, the majority of them express CD19. It's not clear what the role of CD19 in this line of therapy it will has, but in terms of toxicity of the product. But the previous studies in relapsed refractory myeloma had demonstrated activity, and they used a new it's manufactured the fast CAR platform. That is, instead of manufacturing cells between a month, it takes 3 days, providing potentially younger and fitter naive T cells. So this the eligibility criteria is for patients with let me put my glasses. Sorry, I'm 15 now. So patients with more measurable disease and had more than there were newly diagnosed myeloma patients who were transplant eligible and transplant ineligible. The primary endpoints were safety, but response rates also was an important endpoint. Here we can see patients all received induction with RVD, received the product, and then received LEN maintenance. These are the patient characteristics. The majority of the patients received this as first line therapy. All the patients received that first line therapy. The median time from diagnosis to infusion was 3 months. The product was safe with very low grade of CRS, less than 30%. 30%, but it was mostly grades 1 and 2, no ICANS, and no delayed neurotoxicities that we see with other products. And look at the response rate, 100% response rate, and 100% of the patients had a very good partial response. And MRD assessment was also very high, more than 96% at 10 to the -6, and sustained MRD negativity after a year. And PFS, similarly, progression-free survival curves, almost 90% in this newly diagnosed population, and no patients died within the infusion during the first 12 months. So it's still preliminary, but a very interesting response rates with this product. I think definitely we'll see more about this product that comes from not from the US, but from China. So we'll learn more about this. There was an update on the anito-cel and also a BCMA targeted CAR T cell therapy from the phase 2 study, Imagine-1. So anito-cel is as opposed to ide-cel or cilta-cel, doesn't use an immunoglobulin BCMA receptor. It uses a non-antibody derived synthetic protein that this provides the size of the protein allows for high affinity with the BCMA receptor and has less tonic signaling, potentially traducing this in less side effects. So higher activity and less side effects. So this study was as a phase 2 study in patients with 3 or more lines of therapy of multiple myeloma. The primary endpoint was overall response rate, and then secondary response, stringent complete response. It included patients mostly with performance score of 0 or 1, so good performance status patients, and that is the target cell dose. So total patients that were finally dosed was 117 with a median follow-up of 15.9 months. So this is a patient population, similar, 117 patients. The majority of the patients were triple refractory, with good performance status. And again, the overall response rates were very interesting, 96%, and they continue to deepen over time with a very good partial response, 88, and stringent response of 74%. Overall MRD negativity to 10 to the minus 5 was interestingly high of 95%, and 10 to the minus 6 was 78%. And similarly, PFS rates were pretty good, but 2-year PFS was 61%, similar to what we've seen with other products, but less side effects in terms of toxicity. So I think many institutions within the city are part of the phase 3 study that is using anito-cel as a second line or later line of therapy. It is encouraging to see more BCMA and less toxic products coming up. And finally, I want to show you this was presented as a late breaking abstract. This is an in vivo CAR T cell product, KLN 1010. This is a phase 1 study of dose finding study for the patients. So as you know, all the products that we have commercially available use ex vivo CAR T cells, where we expand the cells in the lab and then give them back to the patient when patients receive lymphodepleting chemotherapy. In this case, the in vivo CAR T uses a lentiviral vector that is infused to the patient, which it makes the T cells generate the BCMA receptor. So these are the same autologous cells, but are modified in vivo in the patient. So this eliminates the need for lymphodepletion, potentially provides a more fit T cell population that can potentially have a better response rate. So this is the modified lentivirus and the BCMA CAR T, similar to the CAR Ts that we've seen with other products that have the costimulatory molecule and CD3 sigma receptor. So this study included patients with relapsed refractory myeloma after 3 or more lines of therapy. The primary endpoint, since it's a phase 1 study, it was a safety and tolerability, and different doses of the lentiviral vectors was used. But main sites were in Australia. So 4 patients were administered with the lentiviral vector, and all patients expanded. Here we see the CAR T cell product expansion. 85% of the patients all the patients had a good expansion. One patient had more than 40,000 lymphocyte absolute lymphocyte count that required dexamethasone, but no side effects related to lymphocytosis. In terms of response rate, all patients, it's still very early. It's only within the first month, the patients achieved MRD negativity, as you can see here. Pre-light chains and M-spike take longer to clear, but all of the patients are achieving also very good biochemical responses as well. And in terms of side effects, the most important side effect, there were no patients with grade 3 cytokine release syndrome and no delayed neurotoxicity ICANS or delayed neurotoxicity in this patient population. It is very encouraging, that product that we saw. I think it is the way how the future of CAR T cell will be, and hopefully we will see it in clinical use in the future. Thank you. going to be for the future, DNA that we're starting patients. So without the therapy of anemia that we have related to the treatment, so the technology will still make more of the. Now we have all the other pieces of product. We will CAR T cells that I just mentioned. Arlo cells. Interesting product to have. So I think yes, it's an interesting. It's going to be part of the armamentarium. I don't think one therapy excludes the other. Yes.
So it's my honor to introduce the next speaker, Dr. Paul Rubenstein. And honestly, Dr. Rubenstein does not really need an introduction. Everyone knows him. He's a world-renowned hematologist, oncologist, and has done fantastic work in various fields, including, the AIDS-associated hematologic malignancies. Now, just a short anecdote. As many of you know, I was at another academic medical institution in the Chicago area for more than 20 years, and I was considering coming to the University of Illinois. And so I was talking to people, and one of my former colleagues said that you should go there because you'll get to work with Dr. Rubenstein. And boy, was he right. So yeah, no, he's just a fantastic colleague. And today, Dr. Rubenstein will be talking about advances in the classification and in the treatments of newly diagnosed and relapsed refractory diffuse large B-cell lymphoma. Dr. Rubenstein.
Thanks for the kind introduction. Hello, everyone. I probably have too many slides, but we'll try to make this work and move along. Right, my talk is on the classification and how we're making lymphoma therapy tailored to the genetic aberrations that many of these lymphomas have. And in the new treatments, there's so many new trials going on. It's kind of an exciting time. I have no financial disclosures, and lots of these trials are updates from ASH and have not been FDA approved yet. So kind of an amazing slide. CHOP is 50 years old. It was first published in 76, and on the right was the famous Fisher study. Rich Fisher was at Loyola for a bit when he wrote this trial. And actually, there's a Dr. Miller who used CHOP, and Rich Fisher liked Cytobom. So decided to do this randomized trial, and they showed that the overall survival was irrespective of the chemotherapy used. And so CHOP, which was the less toxic, got chosen. And more historical context, Bertrand Coffier he was a hematologist and immunologist in Paris, had this antibody called rituximab, and they decided to add it to CHOP. And the overall survival went from 57 to 70%. And why it's so impressive is that it took to 2002 to do the first immunotherapy for diffuse large B-cell lymphoma. We're at bispecifics now, CD20, CD3 bispecifics, or we call them T-cell engagers. And of course, when the tumor gets in close proximity to CD3, they kill one another. It was approved for second-line therapy, and now there's trials frontline, and we're going to go over them as well. We have lots of new antibodies and T-cell engagers, and we'll get into all of that as well. Something else that is very that is 25 years old is the Germinal Center study. So this is a trial from Rosenwald, and they did next generation sequencing and gene profiling, and they showed that there was two types of DLBCL. One is germinal center, and the other one is called activated B cell, or NGCB. And this is what really changed heme for me. I remember at the ASH meeting, someone from MD Anderson got up and said everyone should get gene profiling for all diffuse large B-cell lymphomas. And I was a doctor at County Hospital thinking, like, how the heck is that going to happen, right? And the Hans algorithm changed that. So using immunohistochemistry, germinal center markers are CD10 and BCL6. MUM1 actually stands for the multiple myeloma oncogene 1. And if you see that expression, it's normally non-germinal center. And we'll get into that as well. And as you can see here, there's a difference in survival from germinal center to non-germinal center. And now we have trials that address this discrepancy, and we'll get into that as well. So let's start getting into the trials now. The first one I want to talk about is called the Polaric study, and polatuzumab vedotin, which is right here. It's an antibody to CD20, and it has 4 molecules of monomethyl auristatin E attached. So it's an antibody drug conjugate, and they combined that with CHP and compared it to R-CHOP. And these are the patients who were on the trial. The median age was over 65, which is, it's always nice because it's nice to test these new trials for patients who are more elderly. And they compared CHOP to Pola R-CHP versus R-CHOP. And this is the first trial. This was in the New England Journal in 2022. It took 50 years to beat R-CHOP. And this is the first trial that did it. And here you can see there's a progression-free survival benefit. Actually, there is no massive overall survival benefit, but you can see the curve starting to separate here. So there's a tendency towards better survival in the Polar chip. And the most important finding was this right here, where it shows that high-grade double hit and triple hit lymphomas and non-germinal center DLBCL responded better. And we'll get to that in a second. So this is the retrospective analysis of the germinal center ABC DLBCL in unclassifiable. And you can see how Pola R-CHP did better with the non-germinal center DLBCLs. Some of the critiques to this, it wasn't powered to demonstrate overall survival for ABC versus germinal center. So this is, but no one can deny that in the ABC subtype, there is a pronounced survival benefit. So clearly everyone now for non-germinal center DLBCL is using Pola R-CHP, and we'll get into that in further. However, the question is, what do we do for the germinal center DLBCLs? I think that remains to be seen, but there is clearly less deaths on Pola R-CHP, and you can see that the curves are starting to separate. So the question is, do we use it for everything, for every type of DLBCL? And I have colleagues who do. I have colleagues who are more selective. Again, the differentiation of these classifications here is double hit and triple hit DLBCL. Double hit is a translocation for MYC and BCL6 and or BCL2. If you have all three, you have a triple hit. What's interesting is BCL6 MYC rearranged are non-germinal mostly, and this is illustrated here. And this is for the first time that the WHO actually made a new category where MYC and BCL6 is diagnosed in the DLBCL and OS category now. And in light of the fact of the POLARIX trial being so efficacious for non-germinal center DLBCL, it is thought for MYC and BCL6 rearranged DLBCL, we should try to go that route. Understand that before, everyone was treated with dose-adjusted EPOC for the double and triple hit lymphomas. And now maybe not so much, right? So because of the incredible efficacy seen on that retrospective study, though it is retrospective, it's an important point made that we have to follow the data and which regimens are more efficacious in which type of, setting. So Margaret Shipp at the Dana-Farber and Lou Stout really for years have been working on the classification by NGS of DLBCL. And there's a new classification system called DLB class. Actually, if you go to the internet, you can put in from next generation sequencing all the mutations, and it'll tell you which class you actually have. And going into it in more specific detail, DLB class 5 is the worst. It has an outcome of 26%, and it's non-germinal center, and there's 5 of them, right? And here are all the characteristics for the fellows in the room. C3, germinal center DLBCL, follicular center. They have lots of characteristics similar to follicular lymphoma. So tazemetostat is a EZH2 inhibitor used in follicular lymphoma. So it's not shocking that the DLBCL's germinal center have similar mutations. And here's the overall survival. So what? Like, how do we use this? This is the NCTN intergroup lymphoma match schema, and you can see the way it's designed is you have DLBCL, you're given 1 cycle of chemo because it takes forever to get NGS. And I don't know how quick it would be off study to get NGS. It's 3 weeks per cycle, but you can see that class 5 here, which is 26%, has an ABC phenotype. So of course, we're going to use the chemotherapy targeted towards that. And really, it's one of the major mutational findings in class C5 is BTK mutations. So here we're adding BTK inhibition with Pola-R-CHP, and they take the genetic profile of each one to see which is the best. And you can see the germinal center, since there was no real difference in the POLARIX trial between germinal center and non-germinal center. It's R-CHOP plus with an EZH2 inhibitor, just like follicular. And this is how we're trying to make the outcomes of the DLBCL better. We talked about T-cell engagers. There's 5 of them, and here they are. And they were incredible as single agents in the relapse refractory setting. So what do oncologists do? When it's great in the relapse refractory, we use it up front, and then we start adding it and combining it with chemotherapy. There is an explosion of trials, with bispecifics and chemo. This is glofitamab and GemOx for relapse refractory, called StarGlow. I like how they choose the names. Now SkyGlow is up front. Pola-R-CHP plus glofitamab. And again, each bispecific are in trials in the front line and in the relapse refractory setting, making oncology now amazing. And I want you guys to remember the first trial, right? The CHOP makes 50, or the Fisher study. We cure about 2/3 of people with DLBCL using R-CHOP. And you'll see now that getting a CR rate in the 100% is now feasible, and we'll get into that. So this is the StarGlow relapse refractory DLBCL with one prior therapy, and our GemOx, which is a salvage regimen. We added the bispecific antibody glofitamab, and you can see the overall survival benefit was clear. We have the trial open now for StarGlow for minority patients. Few minorities were on this trial, but we have it open at the University of Illinois. And the idea is all trials need people of color to be on study. And this is one of the major obstacles I felt with. In my introduction, said I work with HIV and cancer, and while minorities are about 5% of all people on trial, persons living with HIV are completely excluded. So it's important, and it's nice to see how these regimens act in all types of genders and ethnicities as well. But you can see here, Glofit GemOx, this is 60% survival. Up front with R-CHOP, it was 60% survival with that. So you can imagine in relapse refractory setting, we're meeting that bar. In addition, this is a trial, the SUNMO trial, which is mosunetuzumab plus polatuzumab vedotin. And you can see it's just two antibodies. One's an antibody drug conjugate. And you can see the progression-free survival, again, not adding many other chemotherapeutic agents, again, is in the 60% mark, which is an amazing thing. There's a huge explosion of bispecific antibodies with anthracyclines. This is in the frontline setting. And you can see the overall response rates for Pola-R-CHP is here, but here they're adding glofitamab to this. And when we look at the early results, epcoritamab plus R-CHOP, the overall response is 100, CR is 87%, 88%, Glofit Pola-R-CHP 92%. The data is actually quite remarkable, and the safety is quite remarkable too. And we'll get into that on the next slide. So what do we do when someone is in their 80s and needs therapy for DLBCL? Many times we use this regimen called mini R-CHOP, and that was actually published in Lancet. And it had a great 2-year survival of about 75 to 80%. But it's a truncated therapy. And the question is, could we improve on it using a bispecific? Again, the median age here was 81 years of age, and the IPI score was very high. They also had double hit, not many, but germinal center, non-germinal center, and many of these patients had high-risk disease, masses over 7 centimeters, et cetera. Here we have a 2-year overall survival of 82% compared to just 68 with R-CHOP. And this is with an abbreviated chemotherapy regimen, mini R-CHOP, right? So it's an amazing thing that now in the elderly, we can get overall survivals that are quite remarkable. At 2 years, 82%. It would have seemed like fantasy like 10 years ago, but now it's absolutely reality. There's a frontline chemo light, rituximab and glofitamab. They're just antibodies. Polatuzumab is an antibody with chemotherapy, right? It's an antibody drug conjugate. And again, this is in frail patients with aggressive B-cell lymphoma. And just like in STARGLO, they give a pre-chemo to shrink the disease, and then they hit it with the bispecific antibody. Bispecific antibodies, when they have a high tumor burden, you can get lots of cytokine release syndrome, and you can get neurologic impairment called ICANS. And then they continued with Pola-R glofitamab, and then they did a maintenance phase of glofitamab for a total of 7 to 12 cycles, so 6 cycles after the Pola glofitamab and rituximab. Again, the toxicities were very low, which is amazing. And at just 2 cycles of chemo, 58% had a complete metabolic response by PET scan. Pretty impressive. This is after 6 cycles, 75. And this is after the maintenance therapy of just glofitamab. 81% had a complete metabolic response. And again, these patients had an average age of over 80. Here is the response. The 1-year overall survival was 90%, 89.7. Again, this is for the elderly, so it's an incredible advancement on where we were. Again, if you would have told me that someone who's 80 who has DLBCL couldn't get chemotherapy, 90% would still be alive at 1 year, I would have said, again, that's fantasy, but here we are. This is single agent epcoritamab for upfront, single agent in the elderly. And even there, you can get at 2 years, 70% remain in complete remission. It's not as good as this, but again, it's single agent, meaning glofitamab, epcoritamab alone, you need something else to it. And we'll get to more details on that as well. So there are a few lymphomas that upon relapse, you cannot salvage. And Burkitt's is one of those. It used to be primary mediastinal also, but now with checkpoint inhibitors, you can control that. This was in the April 2025 New England Journal. This was just 3 cases, and it made the NCCN guidelines, because to get relapse refractory Burkitt's under control was just unheard of. So 3 patients was enough to make the NCCN guidelines. And I have a patient in the hospital now with HIV Burkitt's who had CNS disease after cycle 3 of suggested EPOCH, and now is getting glofitamab, polatuzumab for relapse refractory Burkitt's. Again, if you would have ever told me anyone could publish 1 case report with relapse refractory Burkitt's and get them into a complete response, I would have thought it was impossible. Let's see how my patient does with this regimen, but it's extremely exciting. This is a trial called the SMART STOP trial. And this was just presented at ASH by Jason Weston, who's at MD Anderson. And what's cool about this trial is lenalidomide's a pill. tafasitamab is an antibody, rituximab is an antibody, and acalabrutinib is a pill as well. So there's no chemo here. And the idea is, can we treat DLBCL without chemotherapy? Let's look at the data. The problem with these trials is there's so many now. And how do you choose? This is just a few of them. And you can see that it's an incredible thing. And we're going to have a hard time choosing, I think. But too many choices, I think, is a good thing. Going back to the SMART stop trial. So LTRA is lenalidomide, tafasitamab, and these are the non-chemotherapeutic agents. They started with 4 cycles. Those who made it to CR competed and had the LTRA with 2 cycles of CHOP. And those who had a partial response got 6 cycles of chemotherapy plus the LTRA. You can see it's only CHOP because the LTRA has rituximab, right? So that's why. And again, the average age is over 70, so very well tolerated. There were 7 patients actually above 80 who did extremely well. And there were essentially 4 arms. So this is the response after just LTRA. 57% had complete remission. And this is for, again, for upfront DLBCL. Who would have ever thought that? And we'll get into the outcomes here as well. These are the outcomes after each arm. So people who had a CR got 2 cycles of chemo plus 6 extra cycles of LTRA. And here you go. 96.7% had a complete response. Very impressive. And some had progressive disease. Actually, in the ASH presentation, it was the 2 people out of, who were over 80 after LTRA, after getting into a CR, said, that's good enough for me. I'm not doing any more. And now 2.5 years later, they're still in remission. So it's kind of an amazing thing. So all patients, the overall survival is 98.4%. How insane is that at 2 years? And 86.5% was the progression-free survival. Let's look at each one of these, A and C, together. So A had a complete response, had chemo plus LTRA for 6 extra cycles. And there's the probability of survival. The Kaplan-Meier curve is just completely straight. You can see if you had CR here, the chemo does add something. So here you can see that you had 4 patients who progressed. What about the patients who had partial responses? They still didn't do that great, but still 84% at 2 years. And you have to remember the Bertrand-Coffier paper, which had an overall survival of 68%. Still, it blows it away. And it shows that you can actually give chemo with targeted agents and the survival benefit is maintained. So if you know how to mitigate the adverse events, make sure about the ICANS, et cetera, for the bispecifics. You can see that these trials are manageable. So we have a lot of T-cell engagers. Even CAR T, in a way, is a T-cell engager, right? We withdraw T-cells. We get them manufactured to include a receptor to CD19, and then we reintroduce the T-cells back into the patient, and we let the T-cells do its thing. Back to HIV and lymphoma. HIV, people living with HIV were excluded from all CAR T studies. If you take T cells from someone with HIV, some of those T cells are infected with HIV, and no one wanted to genetically modify any of the cells that were infected with HIV. There was a large retrospective study done by the AIDS Malignancy Consortium, which showed it was as efficacious. And I guess that's the end result here. The talking point, the conclusion is treat patients with HIV like they don't have HIV, and they do just as well. And now we have the first prospective study open at UIC for patients with HIV in need of CAR T to finally prove the point prospectively that it's safe. You can see that CAR T or bispecifics in terms of efficacy. One, for bispecifics, you need to give it for a long period of time. For CAR T, they like to say this word, one and done. But you can see that if you look at the pool 1 year progression-free survival, it's not that different. And I'm from Argentina originally, and it's a third world country. I think for third world countries, bispecifics will be a game changer because you don't need a transplant center to give a bispecific. Someone in the north of Argentina where they don't even have running water, they have latrines still, they can get bispecifics, right? You just have to know how to give it. And I think worldwide, it's an incredible advancement. These are all of the T-cell engaging therapies, including CAR T, early relapse disease for CAR T. You can see that there's the engagers for lymphoma. There's CAR T for follicular lymphoma, axicell, tisocell, lysocell. I focused more today on the bispecifics, but we could talk hours on CAR T as well. Mantle cell lymphoma, it's indicated for third line relapse refractory disease. But again, the question is choice, and how can we actually leverage the choices that we have to most benefit our patients? How much time have we? So this is the one slide that's the most important one for me, but it should be for everyone, I guess. Between 2017 and 2020, 2,241 patients were treated third line for DLBCL, which meant all of them could get CAR T, yet only 5.4% received CAR T. And that's a tragedy. But I was a county doc, and I still work at Stroger for 14 years, I think I was. And getting therapies that are expensive to the underserved is a problem. It just is. And there's many reasons for this. How many patients did I have at Stroger who came by bus? We have a great transportation system at Stroger. They'll pick you up even in Glencoe as long as you're in Cook County and drive you to Stroger. It's very impressive. But I had a patient who called me who had febrile neutropenia, And I said, where are you? I'm at the ER, you know, you're sick. And she goes, oh, I'm on the bus. I'll be there in about 2 hours, right? And, you know, and this is part of the issues that we have to deal with. And, well, it's what I've dedicated my life to, right? So giving people who are underserved therapies, in the HIV community too, who deserve it, just like anyone else would, but unfortunately they don't get it. So eventually, I think CAR T will be available outside a transplant setting, which is good and bad. You need a transplant setting for when things go really bad. When things go great, it might be perfect until a disaster occurs. So I think we have to really think it through before we take away the criteria where you have to go to a transplant center. These patients can get incredibly sick. So how to leverage new molecular classifications with newer therapies, how to move these new T-cell engagers to the front line. This is an important point. How to improve CAR T accessibility and manufacturing time. I can tell you places like Grady, Ben Taub in Houston, Stroger, getting CAR T in their hands would be life-changing for all minorities, no question. Actually, getting bispecifics was life-changing. Understand that the 1-year survival, progression-free survival between CAR T and bispecifics is not that different. Look at this plateau. This is cell-based therapy, and this is antibody-based therapy. I have to say, the plateaus look incredibly similar. This is from the ZUMA-1 study, which studied ACCREDITED, and this is the single-agent glofitamab in relapsed refractory disease. But as I showed you, adding glofit with chemo can give you results that are incredibly powerful for DLBCL. And bispecific maintenance after CAR T-cell therapy. Do you give bispecifics first in relapse refractory and then go to CAR T? These are all interesting ideas that need to be tested. And I think I had 20 minutes with questions. So this is thank you. By the way, this is the HIV clinic at County, the core center. And I'd love to thank always my patients at Stroger and my colleagues at the University of Illinois as well. Thank you, everyone. Whatever you want me to do. Oh, for that. Okay, go ahead. So he's referring to this. We cannot. It takes a long time to get to. And I think the reason they get it, so the trial is this: you give 1 cycle of chemo, determine the genetic subtype. The only reason you're able to determine the genetic subtype is because it's a clinical trial and the amount of cash they put into it to get these results back to you quickly. But I think we're so far away but it would be fascinating if using this approach improved the overall survival. Oh, was I supposed to repeat the question? So the question was, am I using this in clinic NGS to classify DLBCLs? And the answer is no. Again, as I just stated, but this trial is, everyone's waiting for the results because obviously classification of DLBCL is beyond germinal center and non-germinal center, right? And this is the first trial to really make inroads into that. Chadi. So the question was, what's going on in CNS lymphoma? I can tell you from someone who sees lots of HIV and lymphoma. While most patients never know, most places don't see it, I have 3 to 4 cases of CNS lymphoma a year just in HIV alone. There's lots of trials using ibrutinib maintenance because ibrutinib crosses the brain-blood barrier. My patient with relapse refractory Burkitt's has brain involvement, and glofitamab with polatuzumab, his CNS symptoms improved, which is insane. So it shows that if the bispecific gets into the brain, normally there's microglia in the brain. Are there CD3 cells in the brain? From the looks of it, I just saw him this morning. His facial droop went away. So it's an incredible thing that these bispecifics can penetrate the CNS, and hopefully this will be tested in future.
So thanks for this amazing presentation. And, you mentioned Dr. Fisher, so I had the privilege of working with Dr. Fisher for a couple of years. And it's true that, we've known about CHOP, and finally, we've found something better than CHOP. And same with the GCB versus ABC, which we've known for more than 25 years now. Right. So, and we still didn't know until recently, what to do with it. So it's remarkable to see this advance. So my question was about another outlier, which you, I think, mentioned briefly, the primary mediastinal B-cell lymphomas. And I know it's a really odd lymphoma in terms of the biology and treatments. So do these polar-based regimes have efficacy, or the other things that can be used for this lymphoma?
So Kieran Dunleavy published for frontline primary mediastinal DLBCL dose-adjusted EPOCH. And the Kaplan-Meier curves were insane. It was like 100% survival using dose-adjusted EPOCH. No radiation. The question is, in relapse refractory disease, they all died. So we are changing. There was an intergroup trial because the real world data for dose-adjusted EPOCH for primary mediastinal DLBCL was not that impressive. And the thing that changed the management for primary mediastinal were checkpoint inhibitors. So checkpoint inhibitors remove the inhibitory effect from tissue to T cells, and it allows the T cells. So everything in heme is how to get the T cells to kill your cancer. And you have the checkpoint inhibitors, you have the bispecifics, et cetera. And the checkpoint inhibitors were the only thing to really make a difference in primary mediastinal. So they moved it up front, and that data is not out there yet. But again, we have so many different forms of ammunition now against cancer. How to include all of these in all lymphoma subtypes. We just got funded for plasmablastic to use a BCMA bispecific plus chemotherapy. Plasmablastic lymphoma is my, number one enemy. It's what kills all the time. And really giving dose-adjusted EPOC, following the BCMA bispecific, we hope is going to change the field. So how to include all these new therapies for all of these lymphomas. It's an exciting time. We just have lots of choices. It'll take a while.
Dr. Robinson, we are using more bispecifics in the relapse setting now for patients that are not able to get CAR T. And if we see also that bispecifics are going to be moving to the front line, what are your thoughts on those patients that are not able to get CAR T, but they have a still expression of CD20, for example? Would you consider re-challenging them after a while? Or what do you do in those patients if we are kind of burning all these lines of therapy now?
So point very well taken. I have a patient who has DLBCL, relapse refractory. I put him on Starglow, right? Gemox plus glofitamab. And he comes to clinic last week and his LDH is 1,800. And then I biopsied it and now he's CD20 negative. So like, what do you do? So what we're doing is we're giving chemotherapy with the first bispecific ever discovered, Blincyto. And there was data using blinatumomab for non-Hodgkin's lymphoma, but here is what we need to do sometimes and think out of the box. I think it's great that we're using it up front. I don't think we should not give it. I think our patients who are underserved at the county or wherever deserve to get the best frontline therapy, and we move forward there. How to get patients who are underserved insurance to get transplant and these things, that is the challenge. And people think, well, everyone has insurance. No, that is not true. I can assure you that at county, there are many US citizens who don't have insurance, who need an allogeneic stem cell transplant and cannot get it. Now, it's easier to get them insurance, but it is still a mess. So we have a lot of work to do.
More questions? Nicole, do you want to make an announcement for, yeah.
So we're going to go ahead and proceed to our break. I want everyone to be back at 4:35 if possible. And we still have some box lunches and some salads. You guys have found all the snacks and sodas. And in the boardroom, in about 5 to 10 minutes, we're going to start the products eater. It will also be broadcast in the same Zoom webinar that you guys online are currently watching these presentations through. So don't go anywhere if you're interested in viewing the products eater. Otherwise, we will be back in the general session room at 4:35.
Thanks again to Dr. Rubenstein for an amazing, amazing presentation. Thank you.
That's what we need.
Yeah.
Yes, I'll come into the room and help with that. Or not, okay, yeah, between the two of us. The good thing that works is sound better, and then you're not trying to sound like a question. Yeah. I'm gonna go tell what you guys know. We're all good to go.
Testing. Yeah. All right, folks. I think we are ready to hope you all enjoyed your break, and we're ready for the rest of our talks. So the next talk is by Dr. Ana Avila. So Dr. Avila trained at the University of Illinois for a fellowship, and we were very, very lucky that she decided to stay on and work with us. And she's an expert in multiple fields, including in myeloma, and just fantastic to work with. And Dr. Avila's talk will be about optimizing immune-based therapies in myeloma, from T-cell fitness to clinical outcomes. Dr. Avila.
Thank you, Dr. Kinney, for all the kind introduction. Good evening, everyone. Tonight I'm trying to focus on an update on bispecifics in multiple myeloma and try to be, as concise and trying to present, the most important trials so far. So I don't have any disclosures. So ASH made it pretty clear last year that the question is no longer whether bispecifics work. We know that they're a potent, very powerful tool in myeloma. Now the trials are looking more whether they can be introduced earlier in earlier lines. And the question is really, what is the optimal timeline to introduce bispecifics in myeloma? So there are different strategies, and we can see there have been trials in newly diagnosed multiple myeloma, either transplant eligible or ineligible, and I'll talk a little bit more about transplant eligible and this trial specifically. We're also seeing bispecific as immunoconsolidation after induction, even consolidation after CAR T cell. And I'll also going to talk about the late-breaking abstract, the landmark trial of MajesTEC-3 that hopefully is going to change practice pretty soon. And I think one also pretty new and exciting topic is to look at limited duration therapy with bispecifics. And this was a poster abstract that honestly I think it should have been an oral, but kind of introduced a new concept of using fixed duration treatment in specifics and at kind of shifts to that, kind of CAR T cell mentality, one and done type of treatment. So to start with, this is the IFM 2021 trial in the newly diagnosed area. And there's a couple of other competing trials in this space in transplant-eligible newly diagnosed myeloma, which I think I talked last year about this during the summer series. So we presented Magnetism-6, MajesTEC-7, looking at a triple combination with an IMiD, a bispecific, and daratumumab in the transplant-eligible patients, MajesTEC-7 as well, looking at that combination. But what this trial brings that is new is an all-antibody regimen, a doublet regimen, within a more specific patient population, looking only at elderly and frail patient population. So this was a phase 2 multi-center trial from the French consortium. So it was an academic trial looking at newly diagnosed patients with myeloma, transplant eligible, 65 years or older, and patients had teclistamab and daratumumab. The teclistamab here dosing was a 2-step dose, so different from standard of care, and patients were transitionally right to every 4 weeks. So it's also different that are what we regularly do. Primary endpoint was how many patients achieve VGPR or better after 4 cycles. And interestingly, they had a recent amendment looking also at fixed duration. So, this new concept of fixed duration bispecifics, where after 1 year of monthly bispecific, they transitioned to every 2 months bispecific dosing. And after achieving 2 years of sustained MRD negativity, they stopped the bispecific. So looking at the patient characteristics, as I mentioned, more elderly, frail patient population and median of 73 years old. They even include 87 years old. 1/3 of the patients were 75 years and older, and half of the patient with either had intermediate fit or frail. 1/3 of the patients were high risk. And The response rate was pretty striking. 79% of the patient achieved VGPR after 4 cycles. And at the end of the day, 100% achieved VGPR or better as best response. Regarding MRD negativity, in the available samples that were 27 out of 37 patients that were included, all the patients achieved MRD negativity at only 6 months after therapy. And with a short follow-up of 10.3 months, there were no events of progressions and death that occur in this trial. So another important concept in immune preservation is looking at correlative studies and immune biomarkers. In this study, there were immune remodeling around 6 months with an increase of terminal effector memory T cell, which is kind of reflecting this continuous antigen exposure, and also decrease of the Tregs and NK cells due to this combination, synergistic combination with daratumumab, which I will discuss a little bit later as well in other trials. So I think safety is where this regimen really distinguished itself from the competing trials that I mentioned before. So, looking at hematologic AEs, not really a big difference. CRS, only, grade 1, grade 2, the majority of them, no ICANS. But the infection rate was lower than we can see in Magnetism 6 and Majestic 7. There were 65% all-grade infection with only 14% grade 3 and higher. And there was only 1 patient that discontinued due to infection due to Salmonella. So, having in mind this was a very, elderly, frail population, it was, the infection was manageable compared to other combinations. However, the hypogammaglobulinemia is real, and in this trial, they were very strict in giving IVIG supplementation. 95% of the patients receive IVIG, and they started at first cycle of treatment. And we can see here, the red dots were patients with grade 3 or 5 injection, and you can see that they correlate with the lowest levels of IgG, so some correlation there with hypogammaglobulinemia. But so, I think bottom line, it's an important trial looking at this all antibody regimen in a frail elderly population with manageable side effects. Now moving to the next trial, this is also an interesting concept. So we know nowadays that with our modern triplets, quadruplet induction, our patients respond pretty well, and they end up being in CRs, VGPR, but half of the patients are still MRD positive. So the idea of this bispecific will be to give a fixed duration of a BCMA bispecific as consolidation after induction for patients that are MRD positive to see if we can deepen those responses and see, this could translate in long-term remissions. So this is a busy slide, but basically this is a phase 2 single center study where patients that were newly diagnosed multiple myeloma that at least have achieved 4 cycles of induction or more that were doing well, were FVGPR or better, but were MRD positive, were included. And those patients were to receive 4 cycles of linvoseltamab. And then they had MRD assessment. If they were still MRD positive, they got 2 more cycles of linvoseltamab. If they were MRD negative, they would just continue to standard of care, which most of the patients just continue to get line maintenance. So the idea was to see how many of those patients converted. So MRD, primary endpoint was MRD conversion at 10 to the minus 6. Something important is that how linvoseltamab was given. So initially it was weekly for the first 3 cycles, and then every other week after cycle 4. And also importantly, supportive care. Patients received tocilizumab prophylactically before the first dose, as well as they got steroids for the first cycle. So patient demographics, they included 25 patients, so much younger patient than the trial that I initially presented. 44% patients were Hispanic, 1/3 high-risk cytogenetics. Most of the quadruplets, most of the patient induction was quadruplets, including anti-CD38 monoclonal antibody, and a median patient had a median of 8 cycles of induction before getting linvoseltamab. So regarding efficacy with a data cutoff of November 1st, 2025, from those 25 patients, 19 finished 4 cycles of linvoseltamab, and from those 19, 17 converted to MRD negativity. So the 2 that were MRD positive, 1 already completed the 2 additional cycles of linvoseltamab and converted to MRD negativity. And so far we have 10 patients that achieved 6 months after 4 cycles of linvoseltamab, and they all sustain MRD negativity. So regarding the safety, no CRS, no ICANS, there were no deaths, and you can see most of the AEs were mild, URI, rash, cough, diarrhea, but there were no grade 4, grade 3. There was only 1 grade 3 toxicity, which was a peritonsillar abscess, no grade 4 toxicity, though it really contrasts sharply with what we see in the relapse refractory setting with continuous bispecifics with, you know, a higher rate of infection. So I think that this study, if, you know, this results kind of translate and they hold in time, I think it's going to be a paradigm shift of using bispecific in a very precise setting with a fixed duration and also MRD adapted. So it's going to be something that probably is going to change how we think about induction and consolidation in transplant. This other trial is also consolidation after CAR T cell. So going a little bit, going like a step back, thinking about the key mechanisms of CAR T cell, it's pretty much, you know, the limited CAR T cell persistent, their antigen escape, and also the emergence of a BCMA low, BCMA negative residual myeloma cells. And so here what they want to tackle is actually that, try to see if sequentially re-engaging the T cells with bispecific after CAR T, we could deepen and prolong that CAR T cell response, but using a different target. So here the idea was to give cevostamab after BCMA CAR T cell therapy with 2, goals. 1, eliminate that residual BCMA low, BCMA negative myeloma residual disease, and 2, try to reinvigorate those persistent CAR T cells to go against BCMA positive myeloma cells. So MRD directed, again, fixed duration. So this is a single center academic trial where patients either got ide-cel or cilta-cel as standard of care were enrolled, and after 10-12 weeks of their infusion, they receive cevostamab every 3 weeks for 8 cycles. And then depending, if MRD negativity was achieved, then they went into observation. If they were still MRD positive, they went ahead and got another 8 cycles of cevostamab. Primary endpoint was MRD negativity CR rate at 12 months after CAR T cell. So looking at patient characteristics, 27 patients were included, and you can see here really high risk patient population and heavily pretreated. So 4 median prior lines of therapy, at least 2 high risk heterogenetics in 41% of the patients. Most of the patients received cilta-cel. So I think these are the patients that I think they have a high risk for relapse early after CAR T cell, given all these high risk characteristics. So early in the study, they had to change some and make some amendments due to some allergic reactions with the initial dose that they used. So they, instead of 160 on cycle 1, day 8, they use 132 milligrams IV. Regarding hematologic AEs, pretty comparable to other bispecifics, and no really worsening of cytopenias after CAR T cell. Regarding, cough, rash, those are all side effects that we've seen in monotherapy with cevostamab. No ICANS with this sequentially re-engaging with a bispecific. CRS only grade 2 or 1 was 15%, so not a lot of high-grade CRS. But I think what is important is they did see some unusual immune-related adverse events, although small numbers. They saw patients that had enterocolitis, some neurotoxicity, autoimmune hepatitis, ITP. Fortunately, all those side effects resolved with steroids and supportive care, and the patients were able to be re-exposed to cevostamab after that. However, it's hard to tease out if, those immune-related AEs were due to the sequential use of bispecific, or maybe they were also due already because most of the patients use cilta-cel, and these are known side effects of cilta-cel. Regarding efficacy, at 1 year post-CAR T-cell, over 90% of patients were MRD negative. There was the one patient that progressed and died due to myeloma after 12 months of follow-up. And these are, I think they're interesting early correlative studies. So they looked at PCR of the CAR transgene in peripheral blood, and they saw in the first 2 patients that they were still CAR T persistent at enrollment. And after exposure with cevostamab, they saw a transient highly, expression there. And then the CAR T cell transgene was maintained for almost a year after exposure. So that was interesting. But then those results were not, homogeneous in all the patients. The 3 other patients that they studied, they did not see the same CAR T cell persistent or expansion after cevostamab. So, of course, this degree of heterogeneity underscores the need for larger data sets and longer follow-up. And now, before discussing what I think is one of the most important abstracts at ASH that it's probably going to be practice-changing, MajesTEC-3, I kind of want to step back and review a little bit the biology rationale of using this combination, so daratumumab and teclistamab. So daratumumab, anti-CD38 monoclonal antibody, so does target CD38 myeloma cells, as we know, but that's not the only target. It also reshapes the immune microenvironment by depleting CD38 positive Tregs and Bregs. So it pretty much primes those T cells to be, more active and increase their fitness. And then teclistamab comes and redirects those already primed CD8 positive T cell to have a higher effective killing of the myeloma cells. So really a synergistic immunotherapy combination. And the idea, and essentially MajesTEC-3, is testing whether this immune synergy translate into durable clinical benefits. So the study design, this was a randomized controlled trial looking at Tec-Dara versus standard of care with a Dara triplet combination, Dara-Pom-Dex and Dara-Velcade-Dex. 91% of the patients received DPD. They included patients relapsed refractory myeloma, 1 to 3 prior lines of therapy, including a PI and lenalidomide. And the patient that had 1 prior line of therapy must have been lenalidomide refractory. All the patients were BCMA naive, and their patients that were refractory to anti-CD38 monoclonal antibody were excluded. So they had a total of 587 patients that was randomized 1-to-1. The study started 2021 and then until September 2023. So here it's important to know that it enrolled patients during the COVID-19 pandemic, and we're going to see how relevant that is going to be when we interpreted infection outcomes. So primary endpoint was PFS. It was given as combination Tec-Dara. And looking at disease characteristics, median age was 63 years old. 1/3 of the patient had high risk cytogenetics. I think here it's important to know that the median line of therapy was 2. Most of the patients were lenalidomide refractory and also PI exposed. However, only 5% of the patients were anti-CD38 monoclonal antibody exposed. And I already mentioned there were no patients that were refractory to any monoclonal anti-CD38 antibody that was included. So this is really not fully reflective of our real-world patient population, since we are using quadruplets for induction, and patients, newly diagnosed receive daratumumab at least 4 to 6 cycles in induction. So something to keep in mind. So I think this is one of the most important slides of the presentation. We can see a really striking PFS benefit, 83.4% in Tec-Dara arm at 3 years versus 29.7% for DPD and DVD, with a really unseen hazard ratio of 0.17 in any other myeloma trial. So, pretty exciting. The median PFS for the standard of care was 18.1 months, which is what we see in the real world and actually perform a little bit better than Apollo trial and Castor trial. There were some early PFS events, though, in the TECDARA arm within the first 6 months. But after that, we see a clear separation and sustained separation of the curves with no progressions events beyond 12 months, so kind of like a plateau there. Here's, I think, an important caveat to have in mind when we analyze the PFS curve and is a treatment discontinuation. So there were around 29 patients that discontinued TECDARA, and half of them was not related to disease or progression. So those patients were censored from the PFS analysis and did not contribute to that long-term follow-up. So although I think it's a small proportion and a small number, it's something just, to have in mind when you interpreted that PFS benefit. The PFS benefit was consistent across all subgroups, including elderly patients, high-risk patients. And at 3 years, overall survival was 83.3% in TECDARA, 65% in the standard of care arm. And again, here there was a crossover around 6 to 10 months, and this was due to early infection-related deaths in the TECDARA arm. And we'll talk about it, but basically, COVID pandemic had to do with that. Also, IVIG utilization was not really mandatory at the beginning, so definitely something to see. But after 12 months, though, really you see the separation of the curves and really a potential long-term survival plateau in the TECDARA curve. Regarding MRD negativity, I would say maybe not the strongest data set of the trial, given that MRD was not available in all patients. There were some issues with calibration, some issues with samples, but still 58.4% of the patients were MRD negative at -5 in the TECDARA arm versus 17.1. The median duration of response has not been achieved with TECDARA. DPD, DVD was 23.5 months. And safety profile overall, for regarding CRS, I think that was really manageable. CRS was, most of it was low grade. There was no 3 or high grade CRS events. There was only 1.1% of ICANS. Neutropenia was comparable between the two arms. So I think the safety signal is more in the infection risk for sure. And so I kind of want to pause here because this is where we saw the crossover. So here in the TECDARA arm, grade 3 to 4 infections, so severe infection were 54.1% versus 43.4% in the control arm. And infections-related deaths were 4.6 in TECDARA versus 1.4 in DPD, DVD. Most of those infections rate was associated with hypogammaglobulinemia. And as I mentioned, 3 of those related deaths were due to COVID-19. And 9 of those 12 patients that died did not receive the adequate IVIG supplementation. So after that, they had a protocol amendment where they had a little bit more strict and reinforced IVIG supplementation. And after that change, there was only 1 infection that occurred. So, something really to have in mind when we treat these patients with bispecifics. Regarding the infection density, it was the highest in the first 6 months, where the TECDARA dosing was every week, every 2 weeks. But as soon as you see that we transition to every 4-week dosing, that infection density decreases and actually is comparable between the two arms. So kind of highlighting the importance to really implement IVIG supplementation early. This is another slide, again, reinforcing so that IVIG is not optional, that is critical in our practice, a critical component, and really change mortality in this trial. It was administered regardless of IgG levels, and the idea is to start as soon as possible. This is, I think, a thought-provoking slide, but I think it's whenever we talk about bispecific as second line, we also have to think that, we also have CAR T cell as an option. And even though cross-trial comparisons, they all always have their caveats, I think I kind of want to bring this up to show that the PFS that was achieved with Majestic-3 is pretty comparable to what was achieved with CARTITUDE-4 with cilta-cel, although the populations are different, right? In CARTITUDE-4, there were 1/4 of the patients were CD38 refractory. There were more patients that were DARA exposed. So a different patient population, but still achieving good PFS, this amazing hazard ratio of 0.17. We can see MRD negativity rates a little bit deeper responses in cilta-cel, and the onset of action was also, shorter. And think here with safety outcomes, I bring this here because I think this is pretty much what we have to discuss with a patient whenever we're exposing those two options. Given that, I think in a couple of months, we're probably going to have approval for TECDARA at second line. I think that's probably what we have to discuss with patients. The infection profile is very different, but is also not better than the other. I think, infection rate is really high with bispecifics, although, we have some mitigation strategies. But for cilta-cel, even low numbers, there's still, toxicity that we are concerned about that affect morbidity, which is all this neurotoxicity, Parkinsonism, cranial palsy, MNT. So those two things, we have to kind of discuss with the patient regarding safety profiles. So in conclusion, with this 3-year PFS and OS of 85%, DARA-TEC is one of the most effective treatment options for DARA non-refractory myeloma patients at first relapse. I would think here the ideal patient will be a patient that has relapse on line maintenance that is not ideal for cilta-cel, given is frail or has no access or no caregiver. The question still remains on what to do for those patients that progress on monthly DARA and DARA refractory. I think we still need more real-world data. There's some data there within Majestic-9 and where patients there, 85% of the patients were DARA refractory, and still only with teclistamab monotherapy, they were able to achieve really good responses. So I think bispecific, there's still a role for those patients. The significant risk of hypoglycemia infections mandates the IVIG as early as the first cycle. And I think instead of thinking this as a dual antibody regimen, TECDARA, we should think this more as a triplet, TECDARA, IVIG, given the importance of the IVIG supplementation. I think this, in order to address this infection rate, the cost of giving this continuously, right? This should be studied as a time-limited duration and probably be guided with MRD, as we saw in other trials that I presented early on. I still think of those early events that happened when we were looking at the PFS curves, those patients that progressed pretty early on in TECDARA in the first 6 months. I think those patients are probably the ones that still benefit from CAR T cell. The question is like how to identify them. And I think that's where we're still struggling. So before the last trial, I wanted to give a little bit of background about what are the concerns with this continuous exposure of bispecific. So of course, we saw the infectious related morbidity is real. There's also T cell exhaustion, antigen escape, but also, the treatment burden and costs in our healthcare system. So with that in mind, 6 academic centers had a multi-institutional retrospective cohort, and they saw patients with relapsed refractory myeloma who received either BCMA bispecific or GPRC5D bispecific, and they discontinued therapy for reasons other than progression or death, so AEs, infections, etc. And they only picked at patients that remain in remission after 3 months after stopping therapy. So from 6 academic centers, they were only able to see 23 patients that met all those criteria. And most of them were heavily pretreated, 4 median prior lines, 87% achieved VGPR before discontinuing the bispecific with a median exposure of 7.6 months. And with a median follow-up after discontinuation of 15.5 months, it was striking to see that 82.6% of the patients were progression-free. And again, they were not receiving any therapy or any bispecific, and they were still progression-free. So still, kind of thinking that there's still some lagging effect of the bispecifics still there. And so this retrospective data can only be confirmed with something prospectively. And so that led to the rationale behind this trial, which is called LIMITEC. It's a multi-institution phase 2 trial. It's single-arm, non-inferiority study looking at and testing formally at this limited duration of teclistamab. So patients here had to start teclistamab, be on a VGPR better for 6 to 9 months of therapy, and then they stopped the bispecific. So they were on surveillance, and they had two categories where they kind of made up a early biochemical relapse definition. And for those patients that met that early biochemical relapse, teclistamab was restarted and continued until disease progression. Then if the patient had a true IMGW progression, the teclistamab was restarted, but they gave a more narrow window to see if patients achieve, again, any response when they were re-challenged with teclistamab. So 50 patients total of what they presented in the poster with 4 prior lines. They were also include patients that had prior BCMA exposure. With a median follow-up of 12.8 months, there was a 12-month PFS of 68.2% and 12 months overall survival of 90%. So you see that in Kaplan-Meier curve, highlights that many patients remain off therapy after 1 year after teclistamab discontinuation without any progression. And here is kind of to provide a little bit of biological context of what happened when you discontinue the bispecific. And I think kind of it's striking to see that it takes around 6 months for the immune system to reconstitute. So pretty much, it takes a long time to recover after the bispecific, the B cells to recover. And among the patients that experience early progression of therapy, most of them was due to BCMA loss or mutation as a major driver. And when they were exposed to tacrolimus, they were able to, regain that response. So to conclude, bispecifics are no longer limited to later line relapse. They're increasingly now shaping how we think about induction, consolidation, how we think even with maintenance with MajesTEC-4. And as all the all-antibody regimens move to earlier lines due to this landmark phase 3 trial that I think it's probably gonna change the landscape now, I think the role of IMiDs, PIs, transplant is gonna become more questionable in the front line. And now the new concept, is to look at finite duration therapy, so time-limited duration therapy in a more precise, risk-adapted way. And instead of thinking, is it frontline better than relapse? Probably it's better, the question will be which patients at what disease state and for how long to continue the bispecific to maximize that efficacy, but also preserving the immune health and quality of life of our patients. And with that, I'm happy to take any question.
Thank you so much for the presentation. It was great. So when you have all these agents in the second line, so you have cilta-cel and now potentially Tecdara, what is your rationale to using one before the other, knowing that bispecifics normally work better after CAR T? That's what we've known. So how would you sequence these agents, especially even BCMA, ADCs? What is your train of thought?
Yeah, I think that's a great question. I still think that cilta-cel has had the best result overall, and I think I would, if the patient has access caregiver, I will probably think of cilta-cel first, but also having a honest conversation with the patient about the safety profile, because I think even though the neurotoxicity, the MNTs are small numbers, I think it really affects morbidity. So, having in mind that it is a one-time and done therapy, but it comes with this potential toxicity. And if the patient is comfortable with that, I think, cilta-cel could probably be one maybe of my top choices, and more if the patient is high risk. As we see, the patients that were included in CARTITUDE-4 were more like high risk, refractory to daratumumab. So I'll think more about those patients in that case. If, as we see a lot in UL Health, access, is the issue, caregivers, social support is the issue, and patients cannot, we always get CAR T-cell, then I think bispecific is a really good option as well. Regarding belantamab, I think in the DREAM7, the patients that were included there were less CD838 exposed. So I will say, I think probably I'll think about that as later lines, because I think the Daratech data is pretty robust with the PFS. And hopefully at some point we can think about limited duration for those bispecifics.
Thanks a lot, Dr. Wheeler. That was fantastic. And so now we come to the event we are all waiting for. Dr. Chadi Naban, whom I've known for like a long, long time. I won't say how long, but we were training together at Northwestern. And even back then, there were two things that really stood out about Dr. Naban. One was that he's a Renaissance man, so he's embarrassed. And the second thing is that he's a pioneer. So he always, thinks forward. And if you look, so those two things have not changed for Dr. Naban's. So if you look at his bio, the really long bio that we printed, you can see that he's an oncologist, but he's a lot more than that, right? He's a podcaster, and I had the privilege of appearing on one of his podcasts. And he's an author, so not just books about, cancer and things like that, but from what I'm reading, he's writing a fiction book, right? That's amazing. So we'll all look forward to that. No idea what it's going to be about. And the other thing is, Dr. Naban, he's always like a forward thinker, always on the cutting edge. And so now the thing we are all thinking is AI, artificial intelligence. And so we all want to know what it can actually do. It seems really impressive, right? But how is it actionable? And I can think of no better person than Dr. Naban to talk to us about AI in oncology. Dr. Naban.
Thank you. I hope no, this is the correct one. What do I do? I have to scroll up. Okay. It's PDF because it was too big to email. Okay, let me just do this then. How do I, if we have just some AI help us with this, would be helpful.
She can scroll forward.
No, I need my own pace because I'm not really sure. I just want to make sure. Okay, that's good. I've given talks without slides before. Thank you so much for the invite. Thank you for inviting me. And sorry, I'm the last one between you and the reception. So I thought we'll just do a little bit different talking about AI and precision oncology, because lots of the excellent presentations before were very heavily clinically focused. And I'm going to try to take you a little bit beyond the clinic into a bit of healthcare delivery. And all of the treatments that you actually heard about today, they're very exciting. They're very nice. They save lives of a lot of patients. But it's all about timing. And I'll never forget some of the patients I cared for 20 years ago that I know for sure they would be alive today if we had the drug available. I don't think a patient diagnosed with CLL today, as an example, would die from CLL, provided they get access to therapy. They probably die with CLL. And I've lost actually a lot of patients from CLL, and I'll never forget a patient I lost that he never even got treated because of the immune deficiency state. So like everything is about timing, and if we're going to talk about AI, it's the right time to discuss AI, but more importantly, I would like you to use your imagination today, because some of the things I'm going to be talking about may not be applicable today, but they will be applicable in the next few years. Paul mentioned earlier some of the things that he would have never imagined would happen 10 years ago, and they did. So I want you to use that same imagination, that some of the things I'm saying today may not be applicable this evening, but they will be in the future. So let's start by some definitions. What's precision oncology? And you all know this. We know what traditional therapy is and traditional chemotherapy is. It's therapy that does different between cancer cells and normal cells. But let's really not badmouth chemotherapy. Chemotherapy has cured many diseases, has cured many patients with Hodgkin lymphoma, with non-Hodgkin lymphoma. Testicular cancer is cured with chemotherapy. We don't need any targeted therapy. It's just BEP or EP, and you cure the majority of patients with testicular cancer and so on. So it is important, I say this because it's important just to remember history, and I know how sexy and wonderful to talk about precision therapy, but traditional therapy also has helped us along the way. Now, when it comes to precision therapy, there's a definition by the NCI that I copied and pasted, as you see here, and obviously, it looks at a particular biomarker or a particular mutation that we're trying to target. But I want to take that a step further when it comes to precision therapy. I want to think of the precision dose that we have to give to the right patient. We have to think of the right drug as well and the right treatment sequence. Dr. Avila, we talked a little bit about one of the questions about sequencing between bispecifics and CAR T and so on. So what is the right sequence? And, so for me, when it comes to precision oncology, is taking a step further, not just targeting the biomarker, is also picking the right dose, the right sequence to the right patient, and not just the genotype. The phenotype is also important. We all metabolize drugs differently. We actually consume drugs differently. So it's really critical to look at this beyond. So I think precision oncology 2.0 or 3.0. And why precision oncology important is because the market size, and I know VK here loves these kind of graphs because he puts his entrepreneurial hat and the business hat, and you see why it's important. I mean, the market size in 2035, which is in 10 years, will exceed 340 billion when it comes to precision oncology. The CAGR is about 10%. This is important because it just justifies or explains why many pharmaceutical companies and biotech are investing in this, because frankly, there's a huge market need and it just pays a lot of dividends. And this is not something to be proud of. In the US, we are the largest consumer of precision oncology, understandably so. But I do think when you look at other regions of the world, in Africa, 3% just consume precision oncology. This is really awful because what it tells me there are many patients who don't have access to life-saving therapies. And if I'm going to talk about AI in precision oncology, I would like to bring it home by taking some innovative technology and seeing how can we take this and hopefully help in providing better access to regions of the world that otherwise don't have access. At the end of the day, all of these therapies that we talked about, as nice and wonderful as they are, they only do well if the patient receives the therapy. Otherwise, there'll just be a nice paper and a good H-index. So let's start with the topics I'm going to discuss today. And I promise you, I'm going to try to finish at 6 p.m. So where is artificial intelligence accelerated precision oncology? There's so many things I could take this, but I'm going to focus on 4 areas: precision targeting, precision drug development, and the dosing, as well as the treatment sequence. And the common denominator amongst these 4 things, whether you're picking the target or you're developing the drug against that target, or you're picking the right dose or the right sequence, is clinical trials. At the end of the day, can AI also help in clinical trial acceleration? And I'll give you an example why this is, I mean, there's so many examples the way about this in terms of how long these clinical trials take. You can look at some of the cooperative groups and you see the numbers that tell you when the trial was incepted, and it gives you an idea, you know, when we were fellows, the ECOG 2993, which Marty Tallman was leading locally in ALL, was incepted in 1993, 2993. And we all know when this was reported in the mid-2000s at the plenary session at ASH. So precision targeting, when it comes to targets, we have identified a lot targets without the use of AI. I mean, it's, you know, I mean, an example on the left-hand side, I just put in the ALK inhibitor, for example, in 2007 was discovered by Japanese investigators. And then after that, it was the first ALK inhibitor was approved 11 years later in 2018. And then now we have multiple ALK inhibitors, various generations. And by the way, I know this is Heme Malignancy conference, and on purpose, I thought I'll just intrigue you by putting something about solid tumors. So I know, Paul is very confused. You do have, that's why I chose like some, there you go, there's an ALK there. But then what has happened over the years is patients started undergoing sequencing, and next generation sequencing became almost critical part of the care we provide for patients, because you have to identify the target if there's a drug that you are delivering. And with that, there are millions and millions of sequencing that have occurred over the years. So the ability to interpret the data became very difficult without the help of machines and without the help of AI. So CancerVar is an example of a bioinformatics platform that was developed by investigators at CHOP in Philadelphia and other investigators. And really, it looked at 13 million somatic mutations among 1911 genes and attempted to, and it did, harmonize all of the information so everybody is speaking the same language. In other words, that if there is a particular variant, if I think it's of clinical significance, hopefully Amit agrees that it is of clinical significance. And I was surprised by the fact that pathologists also don't agree, not just medical oncologists, but the CancerVar platform actually resolved 61% of the discrepancies among pathologists. Now, what does that mean? It means that we have to agree what is targetable and what is not. That's really important. That's very, very critical. And the other thing is the ability to look at all of this data in mass. You are able to tell which target is worth looking at, which target you actually, if you see a particular target that is consistently appearing in pancreatic cancer, as an example, in metastatic disease, and everybody agrees using CancerVar and other platform that this is an oncogenic type of variant, then it becomes a target that is worthwhile looking after and trying to tackle and trying to develop a drug against. So it's very important as opposed to a guessing game, because again, this is really what's happening in terms of sequencing. Now, when it comes to developing drugs, we have to, many of the drugs being developed are small molecules, and they often target proteins. And the AlphaFold that led to the Nobel Prize winners, David Baker from University of Washington and others, won the Nobel Prize in 2024 in chemistry for discovering the AlphaFold, which is a way that allows you to know how the folds of a protein are present, because then you can develop the right drug that's going to bind into that fold. And that's going to be critical for the drug to actually work. So, and none of this would have happened without the Human Genome Project that started in the early 90s. And we were able to sequence the human genome. So you're able to tell now what is normal and what is abnormal. So what's critical is once you identify the target, that using AI and machine learning, then you're able also to design the drug that is most suitable against that target. And the reason the AlphaFold won the Nobel Prize is because nobody was able to actually figure out how the folds of these proteins occur, and this is essential component of how drug developers look at drugs as they develop them, because you have to actually make sure it binds to the exact location in that protein. I just wanted to share one example of a difficult drug, pancreatic cancer. This, by the way, is all not in patients. This is in cell lines, so it's not really ready for prime time. But the nice thing about this is it just gives you the power of AI. So the investigators here were trying to look at cell lines. How can they actually look at synergistic combos against the PANC1 cell lines? And they identified 1,700 anti-cancer compound and that had some single agent activities. And then they looked at various pairwise that they can actually pair these drugs together, and they essentially screened millions of models to try to figure out which are the best synergistic two drugs that they can combine together. And there were three groups that were doing this independently, one at UNC, one at MIT. I'm forgetting the third one, but they actually almost came to the same conclusion as which is really the best synergistic combination. Now, of course, you have to take that and validate and do clinical trials after this, but at least you are minimizing the guessing game. Because in general, and I did this, you usually have a drug that you think it works, you have another drug that thinks it works, and you think magically, okay, wonderful, I'm just going to combine both and write a phase 2 study and see what happens. Well, that's really kind of should not be happening in 2026 anymore. We should really be more thoughtful into which combinations, and there's a lot of opportunities to figure this out using AI. Now, when you look at the approved target and precision therapies by the FDA, some of you may think these numbers are, small, or some of you may think that these numbers are actually large or impressive. 119 number of FDA-approved precision oncology therapies as of December 2025. This is different than the target therapies. So, for example, when you look at the FDA does not look at Rituxan as precision therapy. It looks at Rituxan as targeted therapy, and so on. And when it comes to leukemia and lymphoma, there's some overlap, but currently there are 37. That's the number of FDA-approved precision oncology and targeted therapies of leukemia, and then 36 of lymphoma. And by the way, I mean, when it comes, since we're talking about approvals, the FDA has approved other types of AI many years back, but these were usually device type of approaches, mainly in cardiology and radiology. So these exist. It's not that, the FDA has not done that, but essentially to date, and I just did this research this week, I wasn't able to find that there's any drug that is approved by the FDA for cancer, anti-cancer, based on AI. And I'll explain to you why I think that is. This is, by the way, despite the fact that pretty much every pharma company is investing in AI. Honestly, even if the companies are not investing in AI, they have to say they are, because it's the buzzword. You just say AI and people just, okay, great. But when you look at the development stage, the estimated number of AI candidates, about 35 to 40 in phase 1, phase 2, 3, 2025, but none of them are FDA approved. Partly of this, by the way, part of the reason this is happening, I think, it's very difficult to define what is an AI-approved therapy, because every company I know of is using AI in screens and R&D in the preclinical thing, but then unless part of your FDA regulatory submission, you're saying I am actually applying for FDA approval and I've used AI and so on, it doesn't really count as AI-based for approval. But there's a lot of use until the approval actually takes place. Now, moving on into the third piece, which is precision dosing and outcomes. I actually found this interesting paper. The senior author on it is Vivek Subbiah, who's at Sarah Cannon right now. And they looked at 367 phase 1 oncology protocol, and they showed that there's a Bayesian design of these phase 1 trials that have changed from 48% in 21 to 75% in 2024. Why is this important? Because the way we do phase 1 studies still is 3 by 3, 3+3, and you give the drug until the patient is almost going to die, unfortunately, and then you go lower dose and say, this is the one I'm going to use for phase 2. Well, this sounds a bit barbaric, but this is what we have done. And I think maybe it's time to think a little bit differently about how we do precision dosing. The FDA, to their credits, have thought about this, and they launched in 2021 this Project Optimus, with the idea is that Project Optimus allowing us to actually optimize the dosing schedule of a particular therapy. By the way, in real world, we do this all the time without needing the FDA and so on. How many of you have given a particular therapy and it's not tolerated and you modify the dose on your own? You either skip one day on, one day off, or 2 weeks on, 1 week off. I mean, Sutent, when people were using Sutent for renal cell cancer, it was initially approved 4 weeks on, 2 weeks off, and nobody used that regimen. Zeloda is another example. The approved regimen for breast cancer is very different than what people use. At least I believe that's actually the case. But the point is, Project Optimus said, you know what? We need to try to step away from this 3+3 and the way we do phase 1 studies. And let's just think very simplistically and try to add a pragmatic way to this dose. So when you look at the phase 1 studies, this analysis, basically what it means is you actually make a decision on the next dose based on your finding of the previous dose. So there's no harsh adherence to 3+3. And they found that 30% of the studies had dose optimization plans. So this is actually very good news. In addition to that, with all of this information, the concept of digital twins emerged. Digital twins basically is a digital replica of any of us. So we all have, certain characteristics. So every patient has, characteristics, clinical characteristics, radiographic characteristics, genomic characteristics, and so on. Wouldn't it be nice to be able to predict whether the patient is going to respond to a particular therapy before you give it or not? And there are many AI models that simulate. There's a simulation models that allow you to actually predict whether somebody is going to respond to a particular therapy or not, because you have all of this information available on the patient in a digital fashion. So this is an example, and there are a lot of references here, you can look it up, but this is an example when they, on GBM, where the investigators tried to see if they can reduce the dose of radiotherapy for GBM patients without compromising efficacy. And sure enough, they were able to reduce the radiation therapy 17% median reduction without compromising tumor control. This is again in how do you call it, digitally. So it's a simulation model. You still have to take that and try to study it. But the idea is you have more informed way of studying this information. I have to mention a couple of other models that did not necessarily have genomics into them. One that is rather interesting is Scorpio. There are others, by the way. You can find a lot of these. But pretty much it's a machine learning that allow you to take blood tests and clinical characteristics of patients to predict whether the patient is going to respond to immune checkpoint inhibitors. And a lot of this work was done by investigators at Memorial. And then there's also the Loris score that was pioneered actually by the lab of Eitan Rupin at the NCI, and he since has moved. But the idea is, can we actually predict a possibility of a response or not? Because none of these therapies are actually without toxicity. Treatment sequencing, I think this is not looking at the DNA and the RNA. This is really more of how do you decide on the sequencing of therapy? Because this is really important in every single disease. We have many therapies that are approved in a particular treatment, and we struggle in deciding how do we sequence this. Oftentimes it's trial and error. Most of the trials are not looking at this because frankly, it's not, people don't think of this as really critical or important, but I think it's so important. I mean, there's so many treatments that you can think of, myeloma, just an example that we had today, and the same applies for lymphoma. And other diseases. I mean, acute myeloid leukemia is another example. But I think when you think about all of these, all of the data that we have on outcomes and on the treatments, and then try to apply AI modeling on all of this data, it allows you to actually tell which patients did better than others. Sure enough, this is not a prospective, randomized clinical trial, but it's the best thing you could do. And when you do it on millions of data, is really important. Just to give you an example, I don't want to digress, but sometimes I do. When you think about the number of mammograms that we do in a given year, so if you look at the US population and you look at the guidelines and so on, there's about 70 million women who are eligible for mammograms in the US screening just by using the US task force criteria. That I looked at this about a year ago, maybe has changed. Let's assume 20 million don't comply. 20 million don't comply and they don't do mammograms. So we do probably 50 million mammograms yearly. It's a reasonable assumption. 20 million don't, but 50 million would do, right? But the diagnosis occurs, what's the incidence of the disease yearly? It's about 200 to 300,000 new patients diagnosed. So we screen 50 million or not. Wouldn't it be amazing if you're able to actually do a mammogram at baseline, and based on the findings, you could actually tell whether this woman needs to undergo this mammogram every year, every 6 months, every 2 years, and there are others probably that don't need that. We have the information, we have the ability to analyze this, and I think it's very critical because sometimes we have to be able to do this precise way of screening, which is not a topic I actually focus on today. I'll finish up with clinical trials because I think they're really important. There are so many clinical trials out there. Total oncology trials between 2019 and 2025 was 14,500 plus, and 42% of these are precision oncology trials. So we do a lot of trials in oncology, but despite the fact that we do them, and I think Paul highlighted some of this in his talk, less than 8% of adult patients with cancer are enrolled on clinical trials. And of these, they don't represent the patients that you see in the real world. If you look at the US Census, the latest US Census that is published, 12% of the US population is considered African American, less than 6% are represented in clinical trials, out of, by the way, the 8% or less, and 18% of the US population is considered Hispanic, and less than 5% of them are enrolled in clinical trials. So we do a lot of studies, but they don't represent the patient that we see in clinic, and there are opportunities there. And I think trials move at the speed of paperwork. It takes years and years and years for a clinical trial to actually read. And by the time it reads, we start, well, we are not doing this anymore. And this is just an example, a story of this is an investigator-initiated study that I actually wrote. I'll tell you, in 2012, I had the idea. And I shopped it around with some sponsors. I pitched it to a sponsor in 2013 during ASCO 2013. They liked it. It took a year back and forth between me refining the LOI, writing the protocol, edit this, edit that. Weeks go by. It approved for 2014. It took another year until it opened at UFC. It's a phase 1/2 study in patients with double-hit lymphoma in 2015. So it took about 3 years for me to get the study open. And then it took 4 years to even just get the phase 1 enrolled. And it took 2025 until the final report was published. By then, I had left the University of Chicago. I had a couple of jobs after that. And so it took 13 years. And by the way, it was not really earth-shattering. It did not really change the way we treat patients in double-hit lymphoma. But this is an example how slow this this And again, if this was a trial that could save a patient's life immediately, would have been a lot of lives lost of this. So I think we all know this. So where can we bring AI? We can do trial design. AI can help us in trial design. There are opportunities to design the trial to make sure it matches the patient population that we are looking for. So is there a way to change the way we design studies to make sure that these trials are indeed representing patients that need to be enrolled on this trial? There's actually, if you look it up, the Pathfinder is a way that was pioneered by Stanford and sponsors in South San Francisco, and they looked at a way that you can actually increase the way we enroll patients on clinical trials by designing the trials differently. The other thing is site selection. We really have to, we talked about, you have to select the sites that are going to enroll for the patients. I mean, does it make any sense to open a trial with sickle cell disease, for example, in a site that serves 99% of the patient demographics are Caucasian? It makes no sense, but you will see that because sometimes there are other reasons why people open a clinical trial. You know, the sponsor knows the PI and they, oh, well, let's just open the trial. The trial pays a lot of money if you open, so it's going to help the research office, blah, blah, blah. But at the end of the day, it's not right. We have to select the right site for the specific trial. So how about bringing the digital twin into the site level? The digital twin we talked about on the patient level. Let's do digital twin on the site level. What is a site digital twin? It's really all of the information on that site that allows you to understand how best the site will perform. What are the facilities and equipments at the site? So if a site has conducted a phase 1 trial, you should be able to tell what equipment the site have. I don't really need to send a 20-page feasibility questionnaire to the site to open the study. You couldn't possibly have had a phase 1 trial that opened and you're listed at clinicaltrials.gov without having a -80 freezer and -20 and having possibly an inpatient stay and nursing staff and so on. So the digital twin on the site level allows you to understand everything that happens on the site, including, by the way, the demographic data and the health data, which could be anonymized, as well as a comparative environment. There is no reason, in my humble opinion, to open a trial with Dr. Gadi for triple-negative breast cancer if he has 4 other trials. It's not going to help. However, if there's a need, then we have to do it. So looking at the competing trials at a particular site is important, and AI could tell you this. So you'll be able to literally look at all of the information on the site level through trials.gov and other registries. So I would urge us to think digital twins on the site level to try to open trials at the right sites. And then after that, after you open the trials, we have to make sure we enroll patients and retain patients. And this is where predictive analytics are through the EMR by making sure that the patients who are enrolled on trials, you can actually do analytics and tell if the patient is going to be at a high risk of readmission and so on. This is, I would say, this is not necessarily software development. This is a poor man machine learning. You should be able to tell through the EMR, for example, if a patient has A, B, and C, they may have D, and then you could implement strategies to help with that. And lastly is the regulatory. Once you actually have the trial, it's enrolled, you have the drug, you have the regulatory piece. The regulatory piece lies on the FDA on the FDA. The FDA, so I spoke with a couple of my colleagues who are working at pharma right now, and they tell me that they use AI in regulatory submissions in a way to make sure that the data is current, that all of the paperwork is not out to date, to stay up to date with everything that's changing in regulatory. If you're submitting to the FDA versus the EMA versus Japan versus so on. So this is really important. And then on the FDA front, they usually get this packet, could be 50,000 pages. And on one of my podcasts, I had an opportunity to interview Dr. Robert Califf, who's the ex-FDA commissioner, and he told me one of the things we use AI with is to detect fraud. You're able to actually analyze all of this information and tell if there's data inconsistency, and it will actually pop up immediately, so you'll be able to go back and review this. It could expedite things. The FDA has had a lot of initiatives over the past year, if you look at Dr. Macquarie and others, but nothing has yet been available for prime time. But the idea is, on the FDA, they can review faster using AI. If you're submitting to the FDA, you're doing more accurate submission that is aligning with what you are seeking to actually do. Now, not everything is nice and dandy. There are a lot of things with AI. I know I put a positive spin on it because I'm very enthused about it, but I'm not, well, some people do think I am, but I'm not naive enough to believe that everything is going to be great. We really have to watch for a lot of things. I put 10 of things that worry me. We talk about data quality all the time. AI is all about input and output, and we joke sometimes about garbage in, garbage out. Well, let's try to hope we get quality in, quality out. The bias of the data, if the algorithm I'm developing in AI based on young white men, that may not apply to older black men. So we have to be careful about this. The AI hallucinations. The AI is not perfect. It will make mistakes. And then are predictions of the AI applicable to real world? I mean, I think this is really critical. So when I showed you some of the examples in silica and so on, are these applicable to the real world? We need to validate a lot of these things, and validation studies are not easy, frankly. I'll share a couple other things. One is liability. So imagine if you have, you utilize AI, you rely on AI, you make a mistake, are you liable as a physician? Is the company that developed the software liable? Who is liable for this if somebody is going to sue somebody? And who regulates AI? If the company that makes AI is regulating AI, there's a clear conflict of interest. If the government regulates AI, it's too slow. So I think maybe we need to have a combination between private and public sector to regulate AI. But there are a lot of issues with AI that I think we have to be careful about. And lastly, I think at the end of the day, I think AI is going to apply in routine care and in clinical research. In routine care, we are going to actually get much better in deciding the right dose. I just think it is silly to imagine that everybody is going to get a treatment based on body surface area, or everybody gets a 400 milligram of something. I never understood, by the way, why CLL gets different treatment of ibrutinib than mantle cell lymphoma when ibrutinib was being given for CLL. I literally had no clue. I mean, technically, they're both lymphomas, but, and by the way, I asked this question, nobody could answer me. But I think we need to think about this. The optimal patient response screening. We didn't talk about screening, about diagnosis, but I think this is important. And in clinical research, trial optimization, best target, best drug, rapid operations. Trials should not take 15 years to enroll. They really should not take 15 years to enroll. And I think hopefully accurate regulatory submission. So hopefully I did not keep you long, and you can, thanks for mentioning the books. And there are 2 books coming out this year. One actually is on AI in cancer care, where it is not a tech book, not a medical book. It really explains AI in cancer care across the spectrum. And you're right, I'll just tell you the title of the fiction likely is going to be Deception in the Ivory Tower. And that's it.
Thank you, Chadi. So a lot of what you presented is, I think, machine learning done really well, or sometimes not. But a lot of it doesn't really cross over to AI. And I hear this all the time, and I have ideas what this distinction is. But can you elaborate on this? A lot of this is probably not really AI in the conventional sense.
I think, so VK is asking how much of this is AI versus how much of this is really machine learning. And I think let's agree on the definition. I actually was trying to have one slide to define AI. I view AI, and maybe you'll agree with this, as software development on the back end. You have to really, you're trying to almost develop something for the computers or the machines to start thinking like you and trying to give you the output. So the software development, for example, on the site identification is simply having the software read. So you build AI agents that read a protocol, right? I mean, this is building an agent that can read the entire protocol, and then literally the software is able to match that particular protocol against the site digital twin. That would be AI, because you're actually building end-to-end engine software development. Machine learning is basically you're just mining the data and at mass. So like, for example, when we look at the example I gave about the cancer VAR, it is a bioinformatics tool, but machine learning is at its core, because you're really taking all of this data and you're trying to link the genomic data with the clinical data and trying to mine it to see where it is. That's my definition of AI, where you actually develop software on the back end to be able to automate some of the tasks that we do, versus machine learning. What are your thoughts? What are you thinking? Dika was on my podcast this week. You gotta check it out.
Thank you so much. This is really fascinating information. I have a question. So I work in the myeloma space. I work for GSK in medical affairs, and we're always we're doing a lot of trials, and sometimes the data that reads out on the trial is too late, right? The landscape is changing really quickly, and we have superior trials that are being presented at congresses. So would this software, for example, an AI, be able to predict, okay, this trial will be successful? Is there a way for AI to kind of predict that? Like, this is going to be too late by the time it accrues?
So yes, there are ways. It's not the area that I'm personally working on, but yes, there are ways by which you actually. So whenever you have a clinical trial, you have inclusion, exclusion criteria, you have a patient population, and it's fair to say it's probably not going to be unless this is first in human that nobody has thought about. You could actually the inclusion exclusion criteria of this particular study and analyze this against similar patient population at previous trials that have read out and actually predict or project the chances of success. The chances. It's not going to be accurate, but it's almost, almost when you in business you talk about, net present value, and you just say, well, the chance of this succeeding is 80%. And then at GSK say, you know what, we'll take a risk. It's 80%. We'll take a risk and we'll invest in it. It may still fail, but 80% versus if the machine tells you this is likelihood to succeed is about 10% and so on. We use AI every single day in our lives, but I think we are lagging behind in medicine for a variety of reasons. But yes, I think so. There are actually two companies looking at this, doing this. I'll plug one because my friend is a CMO there. Quant AI, that's really exactly what they do. Let's have some sparkling water.
Thanks, Jody. That was amazing presentation. Thank you. And thanks all for coming. Appreciate it. We have a reception now, right?
Quickly let everybody know, if you signed in, that will make sure that I will send you all of the instructions for the post-test eval and claiming credit. So as long as we got your sign in, I'll be sending those emails out to you tomorrow. And then also we have our networking. So we have some beer and wine and of course the snacks still if you're hungry. So please join us for a little bit for chatting and a little networking. Yeah. We did it.
Back. Got it.